Dr. Vivekanandan. Sir will be talking about the pediatric OSA, a multidisciplinary perspective on a growing concern. Over to you, sir.
Very good afternoon to everyone, and I thank Dr. Shankar for giving me this opportunity to talk about this pediatric OSA. This is just a gist about what's pediatric OSA, what should we expect from a pediatric patient, and what are we supposed to talk to the parents, and how are we going to approach the patients along with the other people. Like, you have to include the parents and the multidisciplinary approach. This is what my talk is going to be about. A little bit of the definition, as we all know, that is a disorder of breathing during sleep characterized by either partial or complete intermittent obstructions in the upper airway that disturbs the sleep. So we now term it as sleep distorted breathing, which includes snoring along with OSA. So a normal sleep is the body's housekeeping. A good sleep is a body's housekeeping. And we have two different types of sleep. We know that REM sleep and NREM sleep. And in NREM sleep, we have three phases. Normally, the N3 phase is the slow wave phase, where the adults, we all go in for sleep. Whereas in adult children or adolescent children, it takes about 90 minutes for them to go to their sleep, whereas younger children, they go sleep very early. But this is the period where the sleep disturbance actually occurs. And there are three main groups. Number one, the children with no medical abnormalities, but only a inflamed adenoids and tonsillar hypertrophy, which gives them an airway obstruction in the upper airway. The second group involves the obesity in the pediatric population, which we are seeing in the recent days, especially after the COVID time and after every school has been more, we have a lot of home-based teaching that the student need not go to the school, they can directly sit at home and listen to the teachers. So there is no physical activity. A lot of children with obesity, with this problem we are seeing in the last 4-5 years. And yeah, like I said, obesity, achondroplasia or craniofacial anomalies can also give rise to a narrowed pharyngeal pharynx as well as a narrow upper airway. In Down syndrome, there's a combination of abnormally narrow upper airway and a reduced pharyngeal muscle tone. In most of these children, if we do the inflammatory markers, these are the inflammatory markers that are elevated, commonly the CRP. So examination, this is a very important step. As soon as a child comes, observe the child. Do not directly go and touch the child. Let the child a little bit play along in the area. Hold him, touch him, play with him, talk to him in the language that he understands. And then slowly ask the history from the patients. Directly going and touching the patients, the child will be really scared and they will move away from you. So first, a full ear, nose, throat examination after observing the child for any open mouth breathings. So in case of a very enlarged adenoids or obese child, we could have seen some children in our own clinical practice where they come and they sit with their mouth open and breathing. It's like, or they'll be even drooling. Some children I have, when I talk to the parents for like 5 minutes, they try to sleep off in the chair. So observe them, check for any craniofacial anomalies in the general stata. Examine the nose to establish whether there is an existing rhinitis or evidence of polyposis, and then finally an endoscopic examination can be done, or a X-ray of the adenoids can be done to check the level of the adenoids in the nasopharynx. So these are the accepted scoring system for the tonsils when we examine into the oral cavity, the commonest being the Friedman staging. Then cardiovascular presenting features. This is the main thing which has been published in the US American Authority. There is an increased left ventricular mass and early diastolic dysfunction in patients with children with OSA. A cor pulmonale secondary to pulmonary hypertension is also observed in these kids. And all the children nearly showed improvement in their cardiac status following a surgery. Not only adenoidectomy, but other surgeries like mandibular distraction. So what are the commonest syndromes associated with these neuromuscular conditions? Number one is Down syndrome. Then we have seen children with charge, Treacher-Collins syndrome. Patients with cleft palate, once this palate has been completely operated, their nasopharyngeal airway, it's getting collapsed or getting closed by the enlarged adenoids. So these children go in for a secondary adenotonsillectomy after the palate surgery is completed. So the British Thoracic Society guidelines identified that there is a high incidence of sleep distorted breathing in children with a neuromuscular disorder. This investigations has been spoken by all the three predecessors of mine, so I'm just going brush through this. Still now, the gold standard still is polysomnography for all these patients, followed by a diagnostic drug-induced sleep endoscopy. Treatment. How are we going to treat these patients? These are all children. We are not going to, it's not an adult that we say like go and diet, go exercise, don't eat this, don't eat. They're not going to listen to you. So how are we going to do that? So it's the first time when the patient comes, try to make the parents understand this is his obesity. Okay, this is an inflammatory region, or this is a anomaly of the craniofacial region. So make the patient and the parent understand what's happening. Then an examination and investigation will help us understand what the child is actually undergoing. Then a surgery. Adenotonsillectomy still says the first line of treatment for most of the children who are suffering from OSA without any other abnormalities. Then children with retrognathia, we can go for mandibular distraction. A tongue reduction or tongue-based reduction surgery with epiglotopexy, as Sir said, we can also do that. Continuous positive airway pressure for children who are syndromic, for whom we cannot do any procedures. With cardiovascular anomalies or any neuromuscular anomalies, some children, they won't be able to undergo procedures. For those children, we can put them on a CPAP for a longer period. And nasopharyngeal airway also opens up the airway in cases in the post-adenotonsillectomy era where the child comes back with a residual OSA, we can put these children on nasopharyngeal airway. So this is the thing about a treatment failure. So what happens when adenotonsillectomy is done? The patient comes back to us within 6 months and there is a residual OSA. A sleep endoscopy can be done, which can reveal a part of the lingual tonsils being inflamed, which is in turn pushing the epiglottis more anteriorly and then closing the laryngeal airway. So in that case, we can plan for a lingual tonsillectomy or a epiglotopexy, like Sir said. And concluding, it is a major condition which we are seeing in the last 4-5 years, which has not been seen like the previous method. And also the tonsillectomies and adenoidectomy surgeries have been reduced compared to the last 2 decades. It's because of the good antibiotic availability, and the parents, they are being educated about this in the early age. And it is important to understand the pathophysiology and to appreciate the limitations of the history. The investigations need to be done and the examination in the diagnosing these patients. An intervention in this condition can result in a large and sustained quality of life if these patients are picked carefully, but a good awareness of the comorbidities which can cause complications and with a poor outcome. Thank you.
Thank you, sir. It's a good presentation, Vivekanandan. Congratulations.
Thank you, sir.
It's nice to listen to you talk on pediatric OSA. You are a very apt person for that. I have to mention that your dad, Dr. Balakumar, our former director, was one of the earliest recognized pediatric ENT surgeon. That's why I'm happy you are coming from that tradition and following that.
My pleasure, sir.
And I would also like to tell the audience that he is a good teacher. He is a darling to his students. He has got a huge following in the media, Facebook and Instagram.
Sir.
Congratulations.
Thank you, sir.